Hello, everyone, and welcome to our, what is this, our fifth session, sixth session? I've lost count of how many it is. Welcome to our next session of CME Palooza Spring. This is our afternoon tea session sponsored by the Academy for Continued Healthcare Learning, ACHL. Big thank you to them for their support. Meaningful and sustainable strategies to address disparities through CEhp. Are we there yet? Moderator today will be Amina Abdullah, who's the Senior Director for Community Relations at ACHL. I'm going to turn things over to her in just a minute, but first, let me go through and thank all of our sponsors, our gold sponsors, Academy for Continued Healthcare Learning, ACHL, Clinical Education Alliance, Med Learning Group, our silver sponsors, Academic CME, DKB Med, Haymarket Medical Education, Helio CME, Platform Q Health Education, Red Med Ed, Talem Health. And our bronze sponsors, Antidote Education Company, Bonum Continuing Education, CMEology, Excalibur Medical Education, Global Education Group, Infograph Ed, and Iridium Continuing Education, MedIQ, PriMed, Peerview Institute for Medical Education, RMEI Medical Education, Vindico Medical Education, and Right Medicine. As usual, there are three different ways that you can ask questions. You can use our CME Palooza text line, 267-6660-CME. You can tweet your question using the CME Palooza hashtag, or you can go into and watch on YouTube and go into the chat function within YouTube and ask questions that way. I'll be monitoring all of those and making sure that all of your questions get to our panelists today. We will be using Poll Everywhere for a couple questions for this session. So big thanks to Creative Educational Concepts for sponsoring Poll Everywhere for us. You can either use the Poll Everywhere app, CME Palooza 005, or you can plug in the URL that you see listed below right into a web browser. I'd say go ahead and get that ready to go because we will have a question pretty immediately once we get started with the session. So you can have that ready to go. And last from me, our speaker disclosure slide. Any opinions, discussions, and or conclusions expressed are those of our panelists and do not represent an endorsement by or a position of their employer, its parent company, or affiliates. And so with that, I'm going to turn things over to you, Amina.
Thank you, Derek, and thank you everybody for joining us for the afternoon tea session. As you just said, I'm Amina Abdullah from ACHL, and I'm going to let our illustrious panel members introduce themselves. Starting with you, Sajida.
Hey everyone, I am Sajida Adhikari. I'm an educational program manager in the Continuing Education and Assessment Department at the University of North Texas Health Science Center at Fort Worth. I have been in CE world for almost 3 years now. I joined this world right after my graduation from the School of Public Health from the same university in 2020. And prior to that, I was actually working as a hospital pharmacist in Nepal. I'm very excited to be here today alongside my fellow panelists who have like wealth of experience in this field, and I'm looking forward to this conversation.
Here. Dwayne.
Hi, everyone. My name is Dwayne Brumlow. I'm a grant officer in the Global Medical Grants Division at Pfizer. I am in my 30th year at Pfizer, which is a long, long time, way longer than I ever thought possible. However, only about the last 3.5 years have I been in medical side in medical education. In my role at Pfizer, I'm responsible for prostate cancer and breast cancer. So I have experience in both medical education, quality improvement, and research grants relative to those subjects. I've led a number of collaborative initiatives, a lot of which are focused on the topic that we're discussing today, and I'm very much looking forward to the interaction. So I appreciate you having me, Amina, and others, and looking forward to this.
Thank you, Dwayne. And last but not least, Diane.
Thanks, Amina. I'm Diane Ricchetti. I'm currently ACCME's Vice President of Accreditation and Recognition. In that role, I oversee the accreditation system for physicians. In the U.S., although we have about 17 organizations outside the U.S. who are accredited by us as well. I've been in that role for 12 years, and prior to that, I had the privilege of serving for two different nationally accredited providers, one a medical education company and the other an academic medical center, wherein I was also involved as the director of the AIDS Education and Training Center program in New Jersey. So I've had quite a bit of experience. Not quite 30 years in CE, but pretty close to it.
Thank you, Diane. As you can see, we have all the right people here to discuss today's topic. Such a wide variety of backgrounds and experiences. So I'm really looking forward to today's discussion. So we're going to kick it right off with the first polling question, Derek. So our first question is, I just really want to know how many of you have developed a disparities-focused educational activity in this past year at your organization? Live poll. Oh, look at that.
I feel like we need some Jeopardy-esque
Some music.
Right. You could supply it, Dwayne.
It's been a long time since I've whistled, to be honest.
Acapella?
Oh, look at that. Well, I'm quite impressed. It looks like just over, looks like 75% of you have developed a disparities-focused educational activity. So with that being said, most of the agenda at this year's annual Alliance for Continuing Education and Health Professions meeting focused on disparities in care. So what do you all think what wasn't covered at the recent meeting?
So I'd like to say first and foremost that the Alliance did an incredible job of bringing this topic to bear, really starting off with Dr. Russell Leday's presentation, which I think shook the foundations for those of us who were in attendance, and really set the stage for an entire day where we had opportunities to engage with each other around issues, not only around disparities, but also in looking at DEI issues. So there was a plethora of different information that was covered. So I would be hesitant to say what was missing so much as focus on that there was just an incredible foundation for us and really a call to action for the community who, if we weren't already there, needed to be thinking about these things. And I thought it really helped me and others on my team look at some of the amazing resources that are available in this area to delve into following this foray into those areas. At the Alliance meeting. If we think about it, there's been probably 20 years of really good information available, beginning in around the late 1990s that I can remember. But most recently, we've got some really good hands-on tools available for providers, including things like our own ACCME Academies, DEIA tools for CE professionals, and our diversity, equity, inclusion, and anti-racism continuing education guidelines and recommendations for incorporating DEIA into CE. If we think about what else is available out there, you can look at groups like the AAMC's Diversity and Inclusion Strategic Planning Toolkit, the AMA's Center for Health Equity, the ACPE's guidance to ACPE accredited CE providers to incorporate diversity, equity, and inclusion into their CE activities. I think the question is, was there, where do you start, right? And I think much of the focus that folks have really brought to the forefront is the need to incorporate, to think about disparities in healthcare in the context of existing the CE activities that you're doing. I think Sujita and her team from University of North Texas did a really nice job of supporting organizations who attended her session at the Alliance in really practicing how to do this. So there's so much that is available. The fact that 3/4 of our attendees are developing activities in this framework is no surprise to me, actually. And if you look to the leadership that the California Medical Association has provided in response to the laws that have come into play in California around both cultural and linguistic competency and racial and implicit tackling implicit bias directly in CE, it's really a question of what works for me. I think there's so much out there.
Such a good points that you made, Diane. I love how you talked about the positive that happened at the Alliance and that people should really try to focus on that call to action and what can be done with the existing programs. Thank you for listing all of those resources, just like you mentioned, for those that are part of ACCMEs and that can look into the academy and those tools and the other organizations that you mentioned, such as AMA and the existing activities that exist. So I appreciate that. Even with that being said, let's go into the next polling question so we could see how many people were actually able to attend one or more of the disparity focused activities at the Alliance. You also gave a nice shout out to our panel member, Sajida, who was able to host one of those sessions. Oh, look at that.
Started strong.
It's moving, it's moving, it's moving. Oh, look at that.
Oh, there you go.
So about, okay. Oh, this is just, this is exciting.
Maybe we need to define disparities focused activities, because if you attended almost anything on Tuesday at the Alliance meeting, there was an element of DEI/disparities. So maybe we're being too specific in saying disparities focused. So I don't know. I'm surprised actually at the preponderance of no here.
Yeah, it's like you said, maybe it's in the definition.
Mm-hmm.
But even with that being said, like you said, some of those activities and at least the slides are archived. So if people are interested, they can still go back and view those. But I love how you brought up the point about how we're about 20 years in and people can now look up some of those resources to find out how they can start with where they're at with their programs. And if not, there are a list of resources that Diane just mentioned that you can go back when you decide to view this session later on to go look up how you can utilize some of those good tools and toolkits.
I'll just add in, excuse me, of course, as soon as I talk, I can't have to clear my throat. There's a couple comments from individuals that they're responding no because they weren't at the Alliance conference.
Oh.
So that would perhaps skew some of the results.
That makes sense.
That makes a lot more
True.
sense. I feel better now. Not that they weren't at the meeting, but that there's a rational explanation for it.
Yes. We can go into the next question now, Derek. And so based on you all's experience, do you believe clinical learners have a level set knowledge of what disparities in care are?
I can answer that question. And if I'm talking from my own experience, I honestly feel like there is a varying level of understanding and knowledge of disparities in care amongst the clinicians, because I personally have worked with clinicians who are very well aware of issues like this and who have actually changed the way they practice medicine because of this. And when I'm talking about it, I'm thinking about Dr. Kabani, who is actually our SME for one of the course that we're working on. And she, in her own words, like she was saying in the meeting that she felt like she was prescribing pills to everything. And it felt like she was putting Band-Aid to patient's problem. And she was not seeing the solutions, like she was not seeing the outcomes that she wanted to see in her patients. So, and she realized that like it was because she felt like she was not looking at the whole story of the patient, not getting to know them as a whole. So um, once she started like taking the upstream approach, or if I have to say, like once she started looking at the social determinants of health of the patient, like she felt like she could see that change in outcomes of the patient. And so there are some clinicians who are in that bracket, and I have also worked with clinicians who are actually like part of the solution. They're already working towards it, but sometimes they don't even realize it. And I'm thinking about like the meeting that we had yesterday. Actually, me and one of my co-workers, like we went to a meeting yesterday to meet this group of providers um, who are doing RSS, but they are taking like echo, who are using like echo model to it. And if you know about echo model, like it is designed to promote like equity, diversity, equity, and inclusion. And my coworker, she happened to ask a question to the provider, and I don't remember what exactly the question was, but it was something along the line of, like something related to the disparities and inequities. And she took a moment, like the provider took a moment, and she had a kind of like light bulb moment, and she was like, oh, actually you were right about it. And I was sitting there thinking about like, but you're already working on that. So there are some providers, they're already part of solution, but sometimes they don't even realize it. And as a CE professional, sometimes we have to bring that, like we have to remind them of that. We have to like continue with that conversation. And I have worked with other clinicians where they're like straight up like indifferent about it, like that's not what we do anymore. So I really feel like they're in different levels. And I was also thinking like there are some clinicians, I think they want to be part of solution, but sometimes like they have no idea how they can be part of solution. So I honestly feel like there is like varying level of knowledge and understanding of this in clinicians that I personally work with.
If I could just add, I would also say if you rely on a physician's own opinion of their practice, sometimes that's not as reliable, because introspection is sometimes the most difficult reflection to do. And we all see ourselves perhaps maybe better than we think we're doing. And so, I happen to remember from my public health graduate work where, you would survey physicians and then look at the data, and the self-reported responses were significantly higher almost every time than what the data actually reflected in terms of practicing behavior. So for me, that's an interesting dynamic.
That also kind of reminded me of like another survey report that I was looking at yesterday. It was a survey that was sent out by Physician Foundation in 2022, and in one of their key findings, it said that um, majority of the physicians, they believe that one of the social determinants of health influence the health patient outcomes, right? But when I went down to look at the breakdown of the data, it said like only 23% of the physician believe that it was applicable to the entire patient population. And I thought that was kind of interesting, because social determinants of health it's applicable to everyone. And there was this data published by World Health Organization recently that said like 80% of our health outcomes is attributable to the non-medical factors or the social determinants of health, and only 20% is attributable to the medical factors. And I was like, that's pretty interesting data to look at. So I just wanted to add that as well.
Yeah, good points to make. I think what's comforting is hearing both sides, both points that you both made, Sajid. One is some of the clinicians, like you mentioned, Dr. Kabani, and them recognizing the role that they play. And then also to Dwayne's point of almost that, You don't know what you don't know. So depending on the seat you're sitting in, you might not be able to see those disparities immediately or know that the disparities exist. Or like you said, when you're looking introspectively, not realize that if you are contributing to that, not treating the whole patient, like you mentioned, thinking about those social determinants of health and those things that go on outside of just the physical factors of the ailment that the patient has. So with that, can we go into the next question, which is, next slide. Thank you. So which is, where do you feel that CME and continuing education has a role to play in addressing the disparities in care? How can we help those clinicians realize that there is some disparities?
So I would start this by saying that CME CPD is as a fundamental building block of addressing disparities from the perspective which is, so the clinician can't necessarily change policy, but they can address the disparities in their own practice in terms of how they are treating and what they are doing to support patients where they are. I think this is, I'm going to bring up the California legislation again. Very interesting in that the only state in the country that has a requirement not of physicians around cultural and linguistic competency and implicit bias is California, which the requirement is for the CE provider. And in California, any organization that is based that's accredited and based in California is required to include within any clinical activity instruction on implicit bias. That is, recognizing or helping the learner be aware of their own implicit biases. Some of those could be assumptions around different stereotypes or races or ethnicities, et cetera. And others could be implicit bias in terms of their awareness of what's available or what sort of treatment would be appropriate for persons who are of different ethnicities or races or ages or sexual orientation. So the onus in California is on the CE provider to get the learner to recognize their own biases and thus address disparities that the clinician may be causing. So I think the world looks to CE to keep our clinicians, physicians, and others um, uh, aware of and at least engaged within the current healthcare system, the disparities that are out there, some of which can't be solved with CPD or by the clinician themselves. They might be more policy based, yet we as educators have a role in making sure that the learners know what their options are. So that's a great question that Derek just kicked in. This requirement only took effect in January 1st of 2022 around implicit bias. And in fact, just before that, the California Medical Association authored a set of guidelines specific to implementing these sorts of procedures into CE. So I think we're at a point where we've got a common language and sort of a laboratory where this is going to be happen. Because even though the requirements around cultural and linguistic competency were in place since 2006, the standards and the requirement that it also include implicit bias didn't come into play until 2022. So we will have data for sure. So Brian has asked quite a question here. Behavioral and the vast under recognition of bias and heuristic. Thank you. Oh, it's a comment. You're welcome. I hope hopefully the door will be answered.
Did you have a comment, Sajida?
I agree with what Diane said, and I was also thinking about like when you were talking, and I was able to pull up actually Graham's blog post from December 2022. I kind of like thought about that. Um, in his blog post in December of 2022, Graham, CEO of ACCME, he said, like, I'm going to quote him directly. He said, CME extends well beyond just clinical care. Providers rely on accredited CME to address every medical specialty and cover the full range of topics important to healthcare improvements such as training on implicit biases, communication skills, strategies, and strategies for patient-centered care. And I was thinking, like, we are in a perfect position to address disparities in care because our providers are coming to us already for that education. So if we design education, if we plan and design CEme effectively, then I think we will be able to provide insights on the disparities in care and also provide them with tools and strategies to address this problem. And this was actually the question that we have been asking a lot in our department, and we have made like a lot of process changes in this year so that like we are mindful of this thing and not just like creating X amount of education that does focus on disparities, but being very mindful of it from the very beginning, like from the planning phase. Like, how do we plan, how do we incorporate DEI from like day one when we thought about this education, you know, like in, like we said in the Alliance conference, infusing DEI in each process that we do in our office. So I think it has to be incorporated each and every step and not just like, oh, we create like X amount of education that does focus on disparities.
And when you're talking about patient care, you're talking about applying that lens differently potentially for every patient who walks in the office.
Mm-hmm.
I'm thinking about the little graphic that was presented that showed the difference between equality and equity, right?
Mm-hmm.
And equity is about raising everybody up to a point where so that
Mm-hmm.
they'd all be at a place where they have access to the same kind of care, right? So
Mm-hmm.
the principles I'm going to put in place to address a disparity for someone who is, say, of a sexual minority might be different than I would put in place to someone who is an undocumented immigrant.
Mm-hmm.
So you know that it's not like, oh, I learned DEI, so now I know how to manage patients equitably.
Right.
You have to learn how to apply this lens to understand the social determinants of health and other factors as much as you can as a clinician with one patient at a time.
Right. It's like give them the resources they need in order to get there.
Yeah. Exactly.
Yeah, and understanding social determinants of health and tailoring the treatment strategies per patient, because social determinants of health will differ from patient to patient. So we're kind of like trying to focus on that in our own education. And that was the example we presented in Alliance, like for pain management, how can you like partner with patient, like how do you understand those social determinants of health and work around those with the patient.
That's a good segue into the next question, Derek, if you don't mind, which is what are some of the challenges or limitations with CME and effectively mitigating some of those disparities in care?
You know, I think it starts with the intent, right? And first, let me say, I don't profess to be an expert. I intentionally learn myself about the subject and try to apply it to my role every day. You know, I think when I am a part of the grant writing proposal, it starts there. It starts with a core value of really building trust with patients. It's a very patient-centric perspective that you're shooting for. And so from the outset, when you write a grant opportunity, it should be first and foremost in all that you do to write grants that have the greatest potential impact on all patients. So that is sort of the starting point. And then list examples of how that, how you hope that submissions would follow through on those areas of interest. And then I think from the opposite perspective, having reviewed a number of grants, proposals that come in, to make sure that everyone on the panel has a responsibility in really evaluating those submissions through a lens of DEI. And I've taken a step to actually place these kinds of subjects in what I would just call a grading scale, so that each of the evaluators, are fully familiar with the RFP as it's written, and they're fully familiar with what the areas of interest are as it relates to DEI. And we're intentional about the way we score, for lack of a better word, those submissions. So you have to sort of base it in summary in your core values of building trust, and additionally be intentional about what you write, how you look to evaluate, and actually follow through on that in the evaluatory process.
Anybody else want to expand on that? That's such a good point. I think what I like is how you started off with it being patient-centric, and no matter what seat you sit in, is taking the onus on yourself, and the intention being there and being clear about the end goal and what that is, and then working backwards.
We're all busy and we're all human, and so we can get stuck in the process, right? We get stuck in budgets, we get stuck in deadlines, we get stuck in a number of things that can take our eye off the ball. Mm-hmm. And so whenever I'm working with a team, in the very beginning, I'm very intentional about reminding everyone in the room that the goal is to, at the end, land on budget. The goal is to select the best grants, and we have all the tools and the efforts to do that. But we want to impact patients in a positive way. We want to improve the quality of care for everyone, regardless of their circumstance or how they may be in the system that they're in. And that takes intent.
Mm-hmm. That's a good segue into the next question, Derek, which is, next slide, which is, how do you measure success when we talk about disparity-focused CME?
I think I alluded to that a little bit in what I said before. We look for patient level impact, difficult to get to, but that's sort of what I believe to be the most impactful part of the process. We look for submissions that will have a broad reach. We look for submissions that are intentionally partnered with community organizations. I think we would be wise to recognize that as content providers, we don't know everything. So I give special attention to submissions that are partnering with community-based organizations that can ensure impact is appropriate, that can ensure that tools that are developed as a result of education will be well received, that they are constructed with the ideal patients. They look, they feel, they sound sort of focused on all audiences, including all races, etc. So so many times we've seen tools that are perfect, but there's no diversity. So I think those are the kinds of things that you can be very clear about, and I think are useful as it relates. It's not enough, in my opinion, to change the delta between where your knowledge is now and where you want it to be with providers. you have to have tools that are relevant to all communities, that are well received by those communities and have an impact on those communities that are sustainable and measurable.
Agree.
I'd like to jump in here and talk a little bit about how accredited CE is designed specifically to ensure that every provider is measuring meaningful change in their learners. And it starts at the planning process. And as Sujita said earlier, when you're planning for change, you need to be measuring for that change. And part of your responsibility, I would say, as a CE provider, is getting the individual learner to recognize the things they need to change, and including within that how to address disparities. Now, your objectives and the things that you may set out to do might not say change the disparity in access to healthcare for African American women in Chicago around breast cancer. Um, but it may within the learning teach the person who is participating to be able to assess their own abilities to provide care that will help reduce, you're probably never going to eliminate, but reduce the likelihood that they're going to treat someone who doesn't have the same uh, uh, health literacy or access to third party insurance in a way that helps support them or get them closer to health. So you have to develop the activity to make that change, and then you have to decide at the beginning how you're going to measure that change. The CME requirements say that you must measure change at the level of competence, that is the ability to apply knowledge in practice, performance, what the person does in practice, or patient outcomes. And I would put forward that you can do this in a meaningful way at any of those levels, right? So we're talking on the Moores scale, level 5 or higher. Most providers, and I just know this anecdotally, don't have the resources necessary to do research level patient outcomes based evaluation. But if you can get the learner at a minimum to articulate that they've recognized and are going to apply a skill in practice that will relate to their ability, for example, to recognize their own issues, their own potential implicit biases, and how to ensure that they're working equitably across their patients, they can meaningfully uh, make change that will impact some of those disparities. So it doesn't have to be at the kind of level that will get the folks at the grant office excited uh, to meet the accreditation requirements. And I'm all for getting patient outcomes and showing, and we've got great examples in our ACCME provider base of organizations that can show those kinds of changes. And many of them have been generously supported by our commercial supporters in having the resources to do that. But that doesn't mean if you don't have those resources, you shouldn't try, and that you shouldn't be thinking about what you're changing and how am I going to measure it, whether it's looking at data from your health system or asking your learners questions about what they intend to change.
I agree.
Yeah, and I thought about like when Diana was talking about it, I thought about like we can't measure disparity is such a big topic, right? And it occurs in like systematic levels. So we're not I think we have to be very careful with the metric we choose for measurement. And that's what like I got from you when I was listening to you, like being mindful of the metric. Like you can't go to the learner and ask like, oh, what are you going to like address disparities? But maybe like if you're, for example, if I'm thinking of a simple example, if we're talking something about food insecurity, maybe like we can
Mm-hmm.
ask about like, have you started incorporating like screening into your
Mm-hmm.
practice? Like something that can be measured. So I think we have to be very thoughtful about the metric that we want to use for the measurement. And the other thing I was also thinking about was the reflection part, because that's the question that I've been asking myself too, because I'm working on this pain management CE. Um, education, and I'm kind of thinking about my evaluation questions. I do have my outcomes already. I'm kind of like working backwards on it, but also kind of thinking like, do we want to ask like more reflective kind of question, so that like learners can reflect and be like, oh, this is where I was before this course and this is where I stand after the course. So even if I can get anything from that, I think I would take that as a success for my program.
I agree with you 1,000%. And having seen a number of outcomes report that are genericized, for lack of a better word, it tells me that there wasn't a lot of intentional thought about the questions. It was your sort of standard change in learning and report. So I think, again, I keep going back to the word of having the intent. If you begin with the end in mind, then you're more likely to land where you want, as opposed to otherwise not considering it and trying to retrofit an outcome. So it's intent.
Yeah.
And all that's different here is applying or thinking about the disparities that may exist, right? This is all in your planning. So what are the things that are not equitable in our health system for my patients or for the patients of my learners? And and then structuring your evaluation, even if you use that same format. Some people say, well, I've got to go to the ACCME and do an overall program analysis. So I need to make sure that I'm asking exactly the same questions every time so I can quantify this. And it's not difficult to extrapolate change into in a quantifiable way or even a qualitative way, even if you've asked somewhat different questions from in each activity that are tilted toward what you want to accomplish. But the lens in which you design that change and the measurement of that change, what we're saying here, what we're talking about here, is making sure that you're thinking about the potential disparities that the clinician will encounter.
Mm-hmm. Derek, do you mind? We answered a lot of the next two slides. So if you don't mind advancing twice till we get to examples. Yes, that one, exactly. Because they all kind of talked about being intentional when it starts with the planning process, and then also talked about some of the outcomes and the data. So do you mind showing or sharing some examples of successful CE programs that have overcome some of these barriers or had some good outcomes that?
So one of the things, and I'm talking a lot here, so please,
No,
I can
that's the intention.
I can defer to someone else. But one of the things that we firmly believe at ACCME is that our requirements can help catalyze change, and we've seen it. If you go back to the commendation criteria, the set of commendation criteria that were available before 2020, we began to see examples of this back then. When we were asking questions in the commendation criteria regarding addressing barriers to change, regarding engagement with the quality improvement environment. And I went back and looked at some outcome-based material we saw from then, and we saw providers. There was one where they were able to demonstrate improvements in key clinical areas. Here it was pneumococcal immunization rates, BMI assessment, and foot exams in undocumented immigrants, right? So you were looking at a particular population who would not normally have access to this care, who through CE, the provider was successfully able to show that these rates improved. Another great example as we move into the newer criteria, where we've actually required for commendation that you demonstrate that you've achieved outcomes at the level of performance, quality improvement, or patient health, was related also, as Sujita mentioned, one to food security. Here we saw an activity on immigrant health and cancer disparities. They worked on overcoming food insecurity in patients who were potentially in food insecure areas to improve their outcomes as a cancer patient. So this was a terrific example of how CME has actually made those kinds of changes. That question popped up quickly. Let me see if
Let's see. Are you
has the ACCME considered adding criteria for commendation based on DEI? You know, we actually have a task force on DEI, and as you may be aware, one of our strategic goals is to promote DEI. I think our task force has struggled with this because I think in some ways they feel that this is almost a core area, right? I think we'd like to see it not just be optional. Um, but there are so many ways to do it. I just don't know that we've found a way to make it, put it into a criterion yet. I can tell you that without much nudging, we see that providers are demonstrating that these are the areas that they want to show they're addressing with commendation. But it is definitely something that is under consideration. It's more a question of how and how to do that in a way that would be meaningful without it being a checkbox exercise.
Yeah, there was also a guideline that was created by the ACCME working group. Was it in 2021? We did
It
reference
was
that
in
in our
2021. Yep, you actually gave
yeah,
the
yeah,
there's a terrific sort of rubric
yeah,
or outline that you can use to assess all of your CE processes, the planning, the faculty, etc.
yeah. It's a 7-page guide. We kind of take it as our like guiding principle
Uh-huh.
when we are like
Yeah,
working on our own program. So we did share that during the
yeah.
Alliance
And
conference, and we do use that a lot.
And I would point out that that is actually a product of one of our working groups. So
Mhm.
it's not something that ACCM or our board put together. We've been working through our Learn to Thrive meeting at bringing groups of accredited providers together to develop tools such as this. And they have legs. I mean, it's 2-3 years later, and it's become even more important. And I appreciate your making it available as a resource because that is a great resource. But in terms of
Yes.
making this a criterion, I think it's just a question of the best way for us to allow providers to demonstrate it in a way that would be meaningful for everyone.
Thank you for sharing. And it's so nice to see it come full circle. So have you all, next question. Are grantors and providers considering a spectrum of disparities beyond race?
I would say yes to that. I was a part of a project recently where we looked at a number of, let's just call them variables, and that was relative to patients. And it asks questions: is there or are there disparities occurring within a system based upon where they enter the system, whether they're entering into the system from a rural provider versus an urban provider versus an academic center versus a community center. So that was one situation that we looked at. Another would be, is there a difference in quality of care or outcomes for patients dependent upon whether or not they're cash pay versus private insurance versus Medicaid eligible? If so, why? We looked at that. We looked at age. Does someone who is facing a breast cancer diagnosis, for example, in their mid-30s, receive different care than someone who is potentially in an older demographic? So the simple answer is yes. These are a few that we've begun to look at, and I think it opens up a different lens for assessing care. And allows the provider to see the patient through a different lens. So complicated, long-winded answer, but yes.
No, that was exactly what we were looking for with with that answer. It's not a simple question or a simple solution. So it's good to see all the different lenses that it can be looked through. That it the short answer, the short question was, does it go beyond race? The short answer was yes, and these are the ways how. Because as you mentioned before, clinicians, they all sit in different seats from where they're at, so they're treating patients that look like a whole variety of different things, a diverse set of patients as well. So again, it's going to look disparities are going to look different from different perspectives. Can we go to the next slide, Derek? So how do we forge strategic collaborations with other stakeholders in and outside of healthcare so that we can help mitigate some of these disparities?
I was thinking like in the healthcare, I think it's very important to include like patient and their families in the planning process. And I think we really have to like start telling more patient stories in our education. And it's because like I truly believe that like patients should be the driver of their own treatment. Like their treatment plans should be designed based on their social determinants of health, based on what they need, and not based on what clinician thinks they need. Like I think it should be on that. So we need to include more voices in our education so that we are transforming the way we train our clinicians. And I was also thinking like in the healthcare, I think we have to, and I think we're doing a great job, like encourage more interprofessional care, because the same survey that I was talking about that was sent out by the Physician Foundation, in one of their key findings, it said that most of the physicians, they reported that they didn't feel comfortable, or they didn't feel they were as effective in addressing social determinants of health because they didn't feel like they have sufficient workforce in their setting to help with that. So like a physician does not have to do everything, right? There are like healthcare, there is a healthcare team for a reason. So if we can add like more social worker to the team, or maybe more public health professional to the team, maybe more psychologists or
Mhm.
mental health workers, like all
Patient
other,
navigator. Mhm.
yeah, to
Mhm.
navigate those community resources, like we really need to like work on creating a team and working as an interprofessional. And I think it's such a great topic. And also like outside the healthcare, we have like local public health agencies, like government
Mhm.
agencies. And like I said, like when thinking about like food insecurity as a simple example, like collaborating with maybe like a local area food bank, or
Mhm.
like working with government agencies or policymakers to have policies in place to make those food like affordable and things like that. I think there is a lot of pieces to that.
Mhm. Yeah,
Yeah.
Can I
Yeah.
can I just add something
of
really
course.
quick? I was recently a part of a grant selection process. Last year, we had patient advocates on the selection committee with an equal vote to the providers that were evaluating it.
Yeah.
And this year, to sort of expand upon that, we brought in new patient advocates and we're connecting them to someone who's been through this before. So my point is, we're not only diversifying in the language, but we're diversifying in the selection process too, and giving a voice to patient advocates in the actual grant selection, which I think ensures that their voice is being heard and they are a part of selecting what they deem to be the most impactful. So just wanted to mention that as an
That's
option
so
too.
cool.
Yeah. I would piggyback onto that even at a more macro level when we talk about strategic collaborations. CE providers range from organizations that are small hospital and healthcare systems to groups that are part of insurance companies, to government agencies, to the large physician membership organizations. Um, and we all know that these groups are engaged with lots of other folks besides the treaters. And CME, the definition of CME goes beyond just what you do with a patient, but to do anything that would be part of your professional practice of medicine. And we have providers who are effectively developing collaborations in different areas where healthcare policy is made. So I can point to numerous examples from different types of providers, providers working with the correctional systems, providers who are working directly with legislators. So CE can have a role both at the micro level and at the macro level through collaboration. ACCME's criterion on collaborates effectively rewards providers who can collaborate effectively in such a way that they're able to work better together to address population health issues. And we're seeing multiple examples of this. So CE providers are perfectly positioned as a whole to address disparities across the continuum. And I guess I see Derek's message, so I will wrap up.
Well, thank you to our panelists. I think you all came from a very great background. It's comforting to hear that even from the academic institutions to ACCME and even to our grantors, that you all are thinking about how to address disparities and have some solutions in place. So thank you, Derek. Did you want to close us out?
Yep, I'll do a few closing things. Thanks, everyone. That was a great session. Loved all your perspectives. I just wanted to share maybe two comments that we got from from participants, just talking about in the disparities conversation, talking about how they found disparities that surface as a result of zip codes or geographic location in the same county. And then someone else mentioning how that those with intellectual and developmental disabilities also face many barriers and disparities, but often are overlooked in the DEI discussion. So I thought there were some interesting points that were being made online, so I wanted to share those quickly. But now let me add in my slides so I can wrap us up here, and Scott doesn't yell at me for being late. Okay. Thanks again for everyone for listening into our session. Reminder to please take, when you have a moment, take our survey. It's right on the live page. It's only about 6 questions, take you about 30 seconds to do. Really appreciate any feedback you can provide. And then for the next session, which is our 3 p.m. session, nope, it is our 2 p.m. session. What is fair balance anyway? Oh, excuse me. What is fair balance anyways? Question mark. So to do that, just go back to the live page, click on the link, and that session will get started right at the top of the hour, 2 p.m. Eastern. And with that, that is everything from me. Thanks again to our panel. Great job, everyone. I appreciate
Thanks for having us.
Thank you so much.
I'll see you in the next sessions. Bye, everyone.
Bye-bye.
Bye.